So this is a very interesting retrospective study that we presented at European Hematology Association meeting a few weeks ago. And stems from another study that we actually presented here in Lugano yesterday. So maybe I will start from that one. There are, as of now, several randomized trials which have shown retrospectively the end of treatment PET scan may have a prognostic value in patients with follicular lymphoma receiving frontline chemoimmunotherapy. In fact, achievement of complete metabolic remission in these patients prolongs progression-free survival independently from CT-based response. However, we also use very frequently, particularly in the United States, PET scan before initiation of treatment. In first place for staging purposes, and we usually see an upstaging in up to 45% of patients, but also because PET scan is very helpful to identify areas that may be a higher risk of transformation to large B-cell lymphoma. And in fact, every increased unit in SUV maximum is associated in our experience and based on multiple studies with almost a 1.25 times increase in risk of transformation. Very recently, there's been a meta-analysis published by the Europeans where they collected 185 patients from 3 different randomized trials, and they were able to demonstrate the pre-treatment PET scan as opposed to just end-of-treatment PET scan may be prognostic in these patients. In fact, they observed the total metabolic tumor volume associates with progression-free survival independently from FLIPI score, which is a prognostic score that we use in follicular lymphoma. However, we need larger data sets, and most important of all, we also need to look into more commonly utilized PET-based parameters such as SUV maximum in order to confirm this data. So what we have done at MD Anderson, we performed a single-center retrospective analysis, including 346 patients with advanced stage follicular lymphoma, grade 1 to 3A. So if any patient before starting treatment on biopsy had evidence of either follicular lymphoma grade 3B or transformation to large B-cell lymphoma, the patient would not be included in the study. And this patient received treatment over more than 10 years at our institution, and PET scan was done before and at the end of treatment, and SUV maximum was calculated on all of this. Also, it's important to outline that we retrospectively applied 2014 Lugano classification to all end-of-treatment PET scan in order to reassess response more consistently. So what we observed was that, first of all, when we analyzed the association between multiple increment units of SUV maximum and progression-free survival, a threshold of 18 was the one that had the strongest association with a hazard ratio of 1.5. And so we identified this new cutoff as new threshold to separate high SUV maximum from low. And about 15% of patients in our data set had an SUV maximum above 18, so the high SUV. And this used to be on multivariate analysis, the factor that associated with a very high SUV, the only factor was largest lymph node size of 6 centimeters or more. Now, this is very important because in the US, but also in Europe, we tend to do more commonly incisional cord biopsy as opposed to excisional biopsy. But based on this data, again, patients with very big lymphadenopathy also have more frequently very high SUV. So there may be a geographical mapping biopsy bias. So when possible, based on our data, we may prefer excisional biopsy over incisional biopsy in these patients with a very high SUV. And then we were able to demonstrate having a very high SUV associated with lower CR rates, shorter PFS, and higher rates of what we call POD24, which is risk of progressing within the first 2 years. But these applied only to patients who receive as frontline treatment non-R-CHOP-based regimens. Of course, this may just raise concern for undiagnosed transformation. As I mentioned, we just do cord biopsy in these patients. But I think that also, independently from findings on biopsy, these data suggest that in patients with very high SUV, the biology of disease may just be more aggressive, and so these patients may deserve to be treated with an anthracycline-based regimen such as R-CHOP as compared to other regimens such as BR, R-square, or single-agent rituximab. And finally, we saw that very high SUV associated with shorter overall survival. And this brings back to the EHA study. As I'm sure you may be aware, there are currently 2 large randomized phase 3 trials, one from Europe and one from the US, the STILL and the BRIGHT study. that compare R-CHOP to BR as frontline treatment for patients with follicular lymphoma. And one of the studies showed that BR was clearly superior to R-CHOP, but the other showed that was pretty much the same. And it's always disturbing when two large phase 3 randomized studies have incongruent results. But if you look back into the study, the only stratification factor was actually histology, because different types of indolent lymphomas were included in these two studies. So based on our PET scan data, as PET scan seems to significantly affect overall survival independently from the type of frontline regimen, it would be interesting to look back into how PET scan data were distributed among these two groups in these two studies. So that's what we tried to do with this additional retrospective analysis, where we match pair 73 patients treated with R-CHOP and 73 treated with BR based on age, sex, and Philippi score. And what we saw was that, first of all, patients with R-CHOP, at least at our institution, tended to have a higher SUV before initiation of treatment. So again, this is something that hasn't been disclosed neither in the STILL or the BRIGHT study because PET scan was not mandatory before initiation of treatment. But that reflects a clinical concern for undiagnosed transformation in these patients, and so a tendency to treat these patients with R-CHOP as compared to BR. So as a subsequent step, we compared these two groups, and there was a higher CR rate, longer PFS, and longer overall survival for patients treated with BR. However, after adjusting for PET scan, pre-treatment PET scan, this difference disappeared. So I, of course, acknowledge this is a single center retrospective study, so there are many statistical caveats. But what it suggests is that we may either look back into these large phase 3 randomized studies and trying to understand how much pre-treatment PET scan led to incongruency between the two studies, or just keep in mind that in future randomized trials, pre-treatment PET scan may be a stratification factor to be considered.